So first of all, for some reason, my Outlook calendar had this scheduled for midnight this morning. So I don't understand why, but I think we're all 8 hours late. So I apologize for the delay. And again, if you're sitting in the back, I understand there are a few empty seats left in the front. So move up, please. We've got a great grand rounds coming up. You, I hope, all know Dr. Sachin Goel, who's been with us for 3 years now, much to our absolute joy. We recruited Dr. Goel to head our structural heart program, and he's, I think, absolutely amazed me. We've done more procedures than I could imagine, and we have more papers in press than I'm able to count. So thank God Medline's computerized, so when I have to keep up with it, I'll be able to. So Sachin, that's really a wonderful job. I don't want to delay too much, but we recruited Sachin very earnestly 3 years ago, and we're absolutely delighted to have him talk about mitral and tricuspid valve interventions. We've talked a lot about TAVR. That technology is fairly mature now, but Dr. Goel is the guy we've recruited to lead us into the new age. So Sachin, come on up and lead us forward.
Thank you very much, Dr. Kleiman, for the kind introduction, and thank you for the opportunity. Thank you all for coming early on a Thursday morning. So we're going to talk about transcatheter mitral and tricuspid interventions, what we've learned and where we're going. My disclosure slide. So the outline, as you can imagine, is going to be focused on TEER and TMVR for mitral, and TEER and TTVR, which is transcatheter tricuspid valve replacement for tricuspid. So we'll start off with mitral regurgitation. This is a slide we've all seen. As the population is aging, the prevalence of valve disease is increasing, and MR is actually more prevalent than AS in the aging population. This is also a slide that we've seen time and again, demonstrating the large unmet need for catheter-based interventions for mitral valve. This is a paper I wrote when I was a fellow, which was looking at over 1,000 patients with severe MR that were unoperated and only medically managed. And over 5 years, they had a high rate of mortality and a high rate of heart failure hospitalizations when they were medically managed alone. So the mitral valve anatomy, I don't need to go into the details, but as you know, this is fairly complex, which includes the leaflets, the scallops on each leaflet, the chordae tendineae, the pap muscle, and of course the underlying ventricle. These are all important when we talk about the pathophysiology of mitral regurgitation. The Carpentier classification, again, you all know, this is widely described. This is what we look at carefully. This is what the surgeons look at when describing the pathology. Broadly speaking, we talk about primary MR when there is mitral regurgitation, which is secondary to intrinsic involvement of the mitral leaflets and the chordae, and the secondary MR, which is caused by left ventricular or now increasingly recognized left atrial pathology, the so-called atrial FMR. We all know this, the primary and secondary MR, of course, with increasing severity is associated with worse outcomes. And surgical intervention is not always an option. Depending on the study you look at, over 50% of these patients with severe mitral regurgitation may not be surgical candidates due to various reasons, which include impaired LV function, high operative risk, comorbidities, and of course advanced age. These are some of the common reasons. So the MitraClip procedure, or transcatheter edge-to-edge repair, as it is now referred to in the valve guidelines, as you know, the premise behind this is the surgical edge-to-edge Alfieri stitch, which was pioneered by Dr. Alfieri. And the MitraClip is a percutaneous version, essentially, of the Alfieri stitch, where we can accomplish this by transcatheter, transseptal, and transfemoral approach. This is sort of the evolution of the MitraClip over the last 20 years. The first case was performed in 2003, followed by CE Mark in 2008. The Everest trial, which we will briefly talk about, looking at primary MR, was published in the New England Journal of Medicine back in 2011. That, in addition to the high-risk registry, led to the FDA approval in the United States for MitraClip for primary MR. We all know the COAP trial, which was published in the New England Journal of Medicine, which also we will briefly discuss, which led to the FDA approval for secondary MR. And then the most recent ACC/AHA valve guideline update in 2020, the recommendations were moved up to 2A, class 2A for both primary and secondary MR. And then some of the future studies that are underway, we'll briefly discuss these. There have been several device iterations with the MitraClip, just like there have been with TAVR devices. Now we're using the 4th generation devices, which gives us 4 different options for choosing our device. The NT or NTW, and then the XT and the XTW. The X refers to the length of the clip arms, which are longer than the original version, and the W refers to the width. So we have a longer clip arm, and we have a wider clip as well. So we have 4 different options depending on anatomy. So let's talk a little bit about primary or degenerative MR. As I briefly mentioned, the Everest 2 randomized controlled trial was the first randomized study comparing almost 300 patients with primary or degenerative MR randomized to surgery versus MitraClip in a 2-to-1 fashion. This was published in 2011 in the New England Journal of Medicine. And again, this was done with the older generation of the clip, and this were done in patients who were surgical candidates. That's important to remember. So percutaneous repair at that time was less effective in reducing MR than conventional surgery. However, the procedure was associated with superior safety and similar clinical improvements. This is the 5-year follow-up that was subsequently published in JACC. And when you look at the survival curves for MitraClip and surgery, they're essentially superimposed out to 5 years. So there's no difference in the population out to 5 years from a mortality standpoint. Of course, as we know, there is an early increased hazard of reintervention in the MitraClip that was seen in the Everest study. And this was predominantly noted in the first 6 months. Almost 80% of the reinterventions in the MitraClip occurred early on. But after that initial hazard, the curves again are superimposed for surgery in MitraClip in terms of freedom from mitral surgery in the clip arm or the reoperation in the surgery arm. The MR severity reduction and NYHA class were durable out to 5 years. And then this led to the FDA approval for primary MR, for a significant symptomatic primary MR due to a primary abnormality of the mitral apparatus or degenerative MR in patients who were deemed to be prohibitive surgical risk by heart team. The indication has now made it into the guidelines. It was initially a Class 2B indication. Now it's a Class 2A indication for patients with severe MR and suitable anatomy for MitraClip. The anatomic criteria that we use to define the clip, these have evolved as well. A lot of the patients that we are treating now would have been excluded in the original Everest trials. But with increasing experience and improvement in the technology of the clip, especially the ability to grasp leaflets individually or as opposed to simultaneously in the past, and also the longer arms and the wider arms, we're now able to treat a wider range of pathology. But broadly speaking, we like to think of the anatomic criteria as 3 categories: optimal, conditional, and unsuitable. So we're treating a lot more of the middle column here now, with the expansion of the clip. And these include central and non-central pathologies, borderline mitral areas, borderline mitral leaflet lengths, and also wider gaps and wider flails. Of course, patients that are unsuitable even in today's day and age are patients with perforation of the leaflets, severe calcification in the grasping zone, very small mitral valve areas, and a high gradient at baseline, and a very short posterior leaflet. And these are the patients that are being considered for transcatheter mitral valve replacement, which we will briefly talk about later. From a primary MR standpoint, in terms of the future directions, we're looking at the REPAIR MR trial, which is an ongoing randomized trial, randomizing patients at intermediate surgical risk to MitraClip or surgery. And how is the intermediate surgical risk defined? So if you're 75 years or older, that you're in. If you're younger than 75, then you have to have a STS predicted risk of mortality of 2% or more, or presence of other comorbidities which may introduce a potential surgical specific impediment. And patients will be randomized 1-to-1, 500 patients to MitraClip versus REPAIR. And of course, anatomically, these patients should be, the heart team should feel that valve can be repaired with a high degree of success, both with surgery or the transcatheter technique. Moving on to secondary MR or functional MR. This is the vast majority of mitral regurgitation that we see. We've all heard about the COAPT trial. We'll briefly summarize this without going into a lot of the details. So this was published in the New England Journal of Medicine in 2018. Patients with severe secondary mitral regurgitation were randomized 1-to-1 to MitraClip plus GDMT versus GDMT alone. Over 600 patients included in the study. The mean age was 72. Their ejection fraction ranged from 20 to 50%. And here was the primary effectiveness endpoint, which was cumulative heart failure hospitalizations. In the initial publication was 2 years, and now we have data out to 3 years. And what is striking is that the curves continue to separate out to 3 years, highly statistically significant in favor of MitraClip plus GDMT compared to GDMT alone. The number needed to treat to reduce one heart failure hospitalization out to 3 years is 3. What about mortality? Again, the mortality curves separate, and the difference is still statistically significant out to 3 years in favor of MitraClip plus GDMT compared to GDMT alone. And the number needed to treat to prevent one mortality out to 3 years is 8 for the MitraClip. The important point with the MitraClip is also the safety. The device is extremely safe, and the risk of complications is very, very low. So single leaflet device attachment is now less than 1%. Back in the Everest days, the risk was about 5 to 6%, but with improvement in technology, increasing experience, and of course, the imaging capabilities have tremendously improved as well. So this complication is now less than 1%. When you look at the reduction of mitral regurgitation and NYHA class improvement, these are durable at 24 months. Both in terms of MR reduction as well as improvement in NYHA class. In fact, when you look at MR reduction, 99% patients had less than or equal to 2+ MR at 24 months. And just about 80% patients, this is again with the older generation MitraClip. Recall that in the COAPT, the use of the newer generations was very low because the newer generation clip was just being introduced towards the tail end of the study. So about 80% patients had 1+ or less, and about 99% had 2+ or less MR out to 2 years. Number needed to treat, this was a nice slide that I found, just to sort of put things in context. When we talk about the standard heart failure GDMT and the number needed to treat for all-cause mortality, you can see the numbers on the right side there, and MitraClip is again 6 at 24 months, about 8 at 3 years. Here's another slide looking at it differently, looking at the reduction in mortality, actually, with various heart failure therapies, and TEER or MitraClip is on the right side there, almost a 40% reduction in all-cause mortality. Of course, this is on top of guideline-directed medical therapy and CRT when indicated. So that is a very important aspect, and we work very closely with our heart failure colleagues in ensuring that these patients are medically optimized and with current day GDMT. Important point to remember, back in the COAPT days, the use of SGLT2 inhibitors and sacubitril valsartan was very low, whereas now these are standard of care, and we are following the standard heart failure guidelines in optimizing GDMT in these patients. What about the MITRA-FR? About the same time that COAPT came out, the MITRA-FR study came out. This was the European version of the COAPT, and this was published in the New England Journal of Medicine as well. And that study was negative, meaning the MitraClip plus GDMT was not superior to GDMT alone. And a lot has been written and discussed and debated about this. And the bottom line is these were very different patient populations. When you look at some of the characteristics of patients included in the MITRA-FR, it clearly shows that these patients had far advanced disease compared to those included in the COAPT trial. The left ventricular end diastolic volumes were much higher in the MITRA-FR. The effective regurgitant orifice was smaller in the MITRA-FR, meaning these were larger ventricles, and they had less severe mitral regurgitation compared to those that were studied in the COAPT trial. In addition, the success rate of the device and the GDMT optimization was different between the two trials. So Paul Grayburn and Milton Packer came up with this proportionate and disproportionate FMR concept in order to try and tease out some of the differences between COAPT and MITRA-FR. And this is the main slide, which shows that in the patients, in the MITRA-FR group, the patients had a larger or a greater end diastolic volume and a lesser degree of mitral regurgitation when you look at the volume on the x-axis and ERO on the y-axis. Whereas in the COAPT group, the patients still had a smaller ventricular size, but a higher degree of mitral regurgitation compared to the MITRA-FR. So this is an important point, and this perhaps can explain some of the differences. So when we look at the valve guidelines, the 2020 valve guidelines, the criteria for MitraClip in patients with functional MR, they follow the COAPT criteria. And the main criteria are ejection fraction in the range of 20 to 50%, left ventricular end systolic dimension less than equal to 70 millimeters or 7 centimeters, and PA systolic pressure less than equal to 70 millimeters of mercury. So these are the criteria that have been proposed in the guidelines based upon the COAPT criteria, and these are the patients that we think are ideal for TEER and should be considered for TEER after optimization of their medical therapy. This is a quick example. I think we can skip through this. You guys have all seen this multiple times. So a few slides on what other information have we learned from COAPT. COAPT has taught us a lot of things. So the 3-year outcome I briefly mentioned, the curves continue to separate out to 3 years. The MR severity, people always ask, how durable is this result? Am I going to get more MR down the line? So when you look at, I'll focus your attention to the right side here, at 36 months, 99% of patients had 2+ or less mitral regurgitation, and about 84% had 1+ or less mitral regurgitation. Remember these numbers; these are important. These are done with the older generation MitraClips. I will share some data with the emerging data with the newer generation MitraClips. What about residual MR? We always talk about this. How much MR is okay to leave behind? Should we try to strive and obtain a perfect surgical result like the surgeons? Surgeons never leave the room with 2+ MR, right? So not surprisingly, patients who had more residual MR did worse. There were fewer patients, of course, with severe MR that left the MitraClip. But the important point is that even in the GDMT, patients who were able to achieve 2+ or less MR did better than patients who continue to have severe mitral regurgitation compared to mild or moderate or less MR. The other important point is the results were more durable in terms of MR reduction in the MitraClip plus GDMT arm. Here, this graph is out to 2 years. The results, again, as I showed in the previous slides, are durable with the MitraClip, whereas in the GDMT arm, the numbers start to fall off, meaning they progressively get more MR despite optimization of GDMT. The valve leaks more, the ventricle enlarges more, the ventricular volumes increase more, and this has been shown from COAPT. So this is a very important slide to keep in mind. What about EF? The heart failure guys, we discuss, how low is low EF? Is 30% EF patient going to do as well as 25 or, So this has been studied extensively as well, including the COAPT trial. Here's a histogram demonstrating the distribution of the ejection fractions in the COAPT. And they looked at ejection fractions less than equal to 40, or HFrEF population and HFpEF. Again, the criteria was 20 to 50% ejection fraction, recall. And then they also looked at the data with severe LV dysfunction and moderate LV dysfunction. And a couple of slides on this. So it did not matter whether they had HFpEF or HFrEF in terms of the outcomes, combined all-cause mortality, heart failure hospitalization, as well as the individual endpoints. And then when you look at moderate LV dysfunction, severe LV dysfunction, again, patients who had the MitraClip on top of GDMT did much better than patients who were medically managed alone. So the message is that if the ejection fraction is within the COAPT range, 20 to 50%, the end systolic dimension is less than equal to 7, and the PA pressures are not more than 70, it is a Class 2A indication according to the valve guidelines to consider MitraClip in this patient population. What about pulmonary hypertension? Again, recall PA pressures more than 70 were excluded, but there were patients with significant pulmonary hypertension in the trial. This is a paper from COAPT looking at the impact of pulmonary hypertension. They used a cutoff of 50, and no surprises, elevated PA pressure at baseline was associated with worse outcome. MitraClip reduced the PA systolic pressure to a greater degree than GDMT alone. An early reduction in the PA systolic pressure at 1 month after MitraClip was associated with improved outcomes at 2 years, and TIER resulted in reduced rates of death and heart failure regardless of the baseline systolic pressure. So this is important data, but comes with a caveat that patients with PA pressures more than 70 were excluded. So we don't know what their outcomes are, and that is a matter of ongoing research and debate. What about the impact of TR? So this is an important question that comes up. We see a lot of times patients with severe MR who have concomitant severe mitral and tricuspid regurgitation. Again, remember that patients with severe TR were excluded from COAPT, but there were some patients with moderate or more TR, and no surprises again, these patients have more advanced disease, and they did worse compared to patients who had lesser degrees of TR. But again, MitraClip on top of GDMT was clearly the winner and did better compared to patients who were managed medically alone. Moving on, what about the impact of RV function? The RV is becoming increasingly looked at as we study mitral interventions and more so now with tricuspid interventions. So there's this concept of RV-PA coupling, which looks at the RV contractile function indexed to the afterload. And right ventricular free wall longitudinal strain as measured by echo speckle tracking is the numerator, and the RV systolic pressure is the denominator, which is the afterload. And turns out that this ratio is very important in a prognostic marker in patients with heart failure and also with secondary MR. They found a cutoff of 0.5% to define patients with advanced RV-PA uncoupling. And this was found to be an independent predictor of worse outcomes in this patient population with secondary MR on a multivariable analysis. Again, MitraClip on top of GDMT did much better than patients with medical therapy alone, even though they had advanced RV-PA uncoupling when compared to medical therapy alone. So what is not known is how this pans out in patients with severe pulmonary hypertension, which were excluded, and what is also not known is whether RV-PA uncoupling improves after MitraClip. So that is an area that is ripe for research. What about the gradient? This is a very common question that we encounter in the cath lab when doing these cases. Well, how much gradient is acceptable? Are we causing too much stenosis? So this has been studied. This has been debated a lot over the last several years. Share a couple of slides on this. This is data from COAPT looking at secondary MR. They looked at the COAPT population and looked at the residual mitral gradient by quartile. And the mean gradients in those quartiles were 2, 3, 4, and 7. Of course, there are very few people with very, very high gradients, more than 8 or 9, but these are the data. There's absolutely no difference when you look at the outcome of death or heart failure hospitalization stratified by the mean gradient, residual gradient. So the message is, at least from these data, is that try to get as much MR reduction, and a gradient of 5 to 7 is acceptable. What about primary MR? People said that maybe secondary MR is different from primary MR. This is the largest paper on this topic from Raj Makar's group at Cedars-Sinai. Over 400 patients with primary MR. They did the exact same thing, divided these patients into quartiles, and the mean gradients in those quartiles are 2, 3, 4, and 6. And again, on the right side, you can see the primary outcome, which is all-cause mortality and heart failure hospitalization. There's absolutely no difference in the endpoint stratified by the gradient. So again, the message is in primary as well as secondary MR, the goal is to leave the cath lab with 1+ or less mitral regurgitation, just like the surgeons. Surgeons may leave with maybe more 0 or trace MR, but at least the message is 1+ or less MR is better than higher degrees of MR, as long as the gradient is not more than 5 to 7. Moving on, so a lot has been also discussed about COAPT-like and non-COAPT-like patients because of the discrepant results of COAPT and MITRA-FR. And what does this mean? So these are a couple of European studies, multi-center studies. They looked at patients undergoing TIER, and they defined a COAPT-like profile based on the absence of any of the adverse features as listed on the top here. So ejection fraction had to be more than equal to 20. Systolic dimension had to be less than 70. The RV systolic function that they looked at TAPSE had to be more than 15. They had to have less than severe TR, PA pressure had to be less than 70, and no advanced heart failure or mechanical support or intravenous drugs like milrinone or dobutamine. So patients had to have absence of all these three criteria to be COAPT eligible. And when they looked at the outcomes, freedom from all-cause mortality or all-cause mortality and heart failure hospitalizations, the curves were divergent, meaning patients who met these criteria or COAPT-like patients did much better than patients who are not COAPT-like. So that is the main message, and that's why the guidelines also stress on the COAPT-like criteria for referring patients for MitraClip. This is another paper, larger paper, 1,000 patients from the Euro-SMR registry. They stratified these patients into COAPT-like or non-COAPT-like and also MITRA-FR-like and MITRA-FR ineligible based on the inclusion criteria. And on the top is the outcome all-cause mortality. Again, COAPT-like patients did much better than non-COAPT-like patients, but in the MITRA-FR, there was no difference. So suffice to say that COAPT-like patients, EF 20 to 50%, LV ESD less than equal to 7, PA pressure less than 70, if they're optimized on GDMT and they have severe symptomatic MR, please refer them for MitraClip. A couple of slides on advanced heart failure patients. Oftentimes in the hospital, we are called upon to see advanced heart failure or unstable patients. And what do we know about this? So the MITRA Bridge registry was published last year. This was a small study, but important, I think, contribution looking at our 120 patients from 17 centers with severe MR. Mean ejection fraction is 26%. These patients were either listed for transplant or were awaiting transplant or had some contraindication for which they couldn't be listed. So carefully selected patients, they underwent MitraClip, and their 30-day survival was 100%. 1-year freedom from death, transplant, LVAD, heart failure hospitalization was 64%. 15% electively underwent transplant. And important striking data was that 24% no longer had an indication of a transplant due to clinical improvement. So, these are patients, obviously, these do not meet the guideline criteria, but these are patients that we see in real life, and we are often called upon to evaluate these patients. So here's what we know about them. I thought this was an interesting small study that showed that after MitraClip, patients with a very high pulmonary vascular resistance, 5 out of 17 patients, they had significant decrease in their PVR, and they became potential heart transplant candidates, whereas they were not at baseline due to very high pulmonary vascular resistance. What about shock? So this is a publication out of the STS-TVT registry by Mo Al-Kuli and colleagues from the Mayo Clinic. Almost 4,000 patients with shock, severe mitral regurgitation undergoing TEER procedure, mean age 73, STS-PROM 15%, about half were DMR, about a third were FMR, and final MR less than 2+, less than equal to 2+, was achieved in about 88% patients. And not surprisingly, patients that were successfully treated had a better outcome compared to those that were not able to be successfully treated. Of course, this is a very high-risk patient population. As you can see, the mortality is pretty high out to 1 year. In the unsuccessful group, more than 50%. So these are carefully selected patients, and there's emerging data on the impact of TEER and in shock and advanced heart failure patients, and in selected patients this could be considered. What about hemodynamics? We are always very interested in hemodynamics, as are our heart failure colleagues, and it is a bit of a shame that in the COAPT the LA pressure was not systematically recorded. But we look at this carefully when we do the MitraClips. We look at the pre-LA pressure and the post-LA pressure and also the V-wave. And a couple of slides on this. It is clear, based on these data, that the residual LA pressure is an important marker of risk of the patients. So in this paper from the Mayo Clinic, they looked at LA pressure cutoff of 22, and clearly patients who had a lower LA pressure after TEER had a better outcome at 2 years compared to those who had a elevated LA pressure despite reduction in MR. So these are patients who have underlying myocardial dysfunction or stiff LA, and they have high LA pressure. The other concept that is emerging is hemodynamic profiling, and we have some data coming out in this regard as well, but these are data from Minneapolis Heart, from Paul Saraja's group. So what they did is almost 400 patients undergoing MitraClip, they stratified them into 3 types: optimal, mixed, or poor, type 1, type 2, type 3. And what are these? These are based on residual MR after TEER and the mean LA pressure at the end of the case. So if they had residual MR less than or equal to 1 and mean LA pressure less than or equal to 15, they were optimal or type 1. If they had one of the two, it was type 2. If they had neither, they were type 3. And clearly, the patients who were in the type 1 or optimal category, meaning their MR reduction was 1 plus or less, and their mean LA pressure was less than or equal to 15, they did much better out to 1 year follow-up in terms of survival. So this is becoming increasingly important, and we are starting to pay more and more attention to these kinds of profiling. This is a quick slide showing the functional MR staging. You may be aware of the cardiac damage staging in the aortic stenosis field from Philippe Genero. Similar functional staging has been proposed in mitral regurgitation. As stage 1 is LA abnormality. They all have LA enlargement, of course. Otherwise, hard to believe they have severe MR. Stage 2 is significant LV dysfunction. Stage 3 is pulmonary hypertension. Stage 4 is right heart involvement. And no surprise, as the category or staging gets worse, the outcomes of these patients worsens. So the main message, again, from aortic and also from the mitral is refer these patients early. Don't wait for them to be stage 4 because they are not going to have a very good outcome. COAPT risk score, this is a risk score that just came out looking at some clinical characteristics and echo markers. And no surprises, the higher the score, the worse the outcome. A couple of slides on the ongoing studies. One of the studies I already mentioned is a repair MR, which is randomized trial between MitraClip and surgery in intermediate risk. The EXPAND studies are contemporary real-world registries of MitraClip with the latest technology. On the left is the EXPAND study, which is 1,000 patients with the NT and XT, which is a third-generation clip. And on the right side is the EXPAND G4, which is looking at the fourth-generation clip, which is now, we have 4 different types of clips, NT, NTW, XT, and XTW. And an important point is, in the EXPAND registry, which was still the third-generation clip, we found that the MR reduction out to 1 year was 1 plus or less, was achieved in 89%, and MR reduction of 2 plus or less in about 98% patients. So we're seeing more and more patients with 1 plus or less MR with the newer generation clips, as opposed to the Everest and the COAPT, which use the older generation of the clips. So that's the main message out of these. And here is the EXPAND G4. Some of the data is starting to come out. Over 90% of patients now have less than or equal to 1 plus MR. So we are starting to achieve, if I may say, surgical-like results with the advanced newer generation MitraClips. Hence the randomized trials comparing MitraClip versus surgery. And again, safety is outstanding with the MitraClip, as it has been with the previous generations as well. A couple of quick slides on atrial FMR. This is a concept that has been emerging in the last 2 to 3 years. And this is sort of what it looks like. On the left panel, you see a patient with huge left atrium, a small or normal LV, and I'm afraid these movies are not playing, but in most of these patients, the systolic function, ventricular function is normal, as opposed to ventricular FMR, where there's LV dysfunction. They have severe MR. And when you look at a lot has been written about this, including by Dr. Zogby. In the pure atrial FMR, there's pure annular dilatation, whereas in the ventricular FMRs, there is papillary muscle displacement as a result of LV enlargement. So there are inherent differences in the pathophysiology, but the end result is severe mitral regurgitation. And it is a matter of ongoing debate and research as to what is the best way to treat these. Should we focus on their atrial fibrillation? Should we try to get them into normal sinus rhythm? Should we refer them to surgery? Or should they have transcatheter intervention? So this is an area which we will learn more over the next few years. Quick word about the Pascal system. This is another form of edge-to-edge repair by Edwards Lifesciences. This has a central spacer, and the big trial, which was the CLASP 2D, was presented last year. This was comparing MitraClip against CLASP, and there was essentially no difference between these two, and the CLASP device was found to be non-inferior, and this led to the FDA approval for the Pascal device for degenerative MR in the United States last year. Switching gears, moving on to transcatheter mitral valve replacement. This is the sort of the next horizon. There are a lot of devices that are being studied worldwide for transcatheter valve replacement. This was initially with the transapical axis, but is quickly moving on to the transfemoral transeptal axis. Important question is, who are the best candidates for this? So essentially, we like to look at these patients as non-surgical candidates. They are high risk because of more comorbidities and frailties, but importantly, they are not great candidates for TEER. In today's day and age, if patients have severe MR, if their anatomy is suitable for TEER, then that is the way to go, because we've learned so much about TEER and its safety and efficacy. But if they are not candidates for TEER, then it is a reasonable thing to consider them for a trial. And this is a sort of a scheme proposed by the Heart Valve Collaboratory. When we look at TEER patients with straightforward anatomy, complex anatomy, they can be considered for TEER, but patients with complex or prohibitive anatomy should be considered for TMVR in today's day and age. So quick few slides on the Intrepid TMVR. This is the Intrepid and the Tendyne are the ones we have the most experience with. So the Intrepid valve is the Medtronic valve. It is a 27 millimeter bovine pericardial valve. We used to do this transapically, but we're doing this now transfemorally through the transseptal approach. The Apollo pivotal trial is ongoing, which is a single arm looking at primary cohort, about 500 patients, and also the MAC cohort, which is a big problem. But this is an option that is emerging for patients with MAC and mitral regurgitation. And again, these are the kinds of patients that we are enrolling that cannot be treated with MitraClip. Those patients with severe MAC, calcified leaflets, multiple jets, clefts, very short posterior leaflets that are tethered, large coaptation gaps, or where there is difficulty with imaging adequately. So these patients are appropriate for consideration of TMVR. And as I said, this is now all done transfemorally. We've moved away from transapical, although transapical approach still exists. I'd like to share a brief case that we just did. This patient so these are all large sheets, 35 French sheets, almost 40 French outer diameter. So these are done with a venous cut down, but the access is transseptal. You can see transseptal puncture, balloon septostomy, and then the big sheath in the left atrium, and the device is being maneuvered down towards the mitral valve. This is done with fluoroscopy and TEE guidance, and the corresponding 2D and 3D echo images in the lower panel. And this is the final deployment of the valve in the mitral position with rapid pacing, again with fluoro and echo guidance, which is 2D and 3D. So this is sort of just to give you guys a flavor of what we are doing now, what we can achieve with transcatheter mitral valve replacement without having to go transapical. So this is all done transfemorally. And here is the final result, both with 2D and 3D color, showing essentially elimination of mitral regurgitation and no PVL. So this is what we are seeing with TMVR. So the next generation TMVR, of course, is going to be smaller devices, less than 30 French. Hopefully we can do this percutaneously without a cut down. And then the future studies are going to look at randomizing patients to MitraClip versus TMVR. Tendyne, I'm going to skip through this in the interest of time. This is another valve that has been studied. They're already randomizing patients, and there's some published data. So what are the issues with TMVR? I think spend a couple of slides on this. What we are learning as we are enrolling patients with TMVR is there's a high exclusion rate at this time. More than 50% of patients, or even higher in some instances, get excluded. And the main reasons for exclusion are anatomical. One is sizing, because these valves are available in limited sizing. Hopefully that issue will resolve as we get more valve sizes available. But the LVOT is the Achilles heel of this technology. When we put a valve in there, as opposed to surgeons, who cut out the anterior leaflet, we don't have that luxury, although maybe we do. But the anterior leaflet can cause LVOT obstruction. And this is one of the main reasons. And we are able to predict this to some degree with the help of detailed CT analysis, but we aren't very good at predicting this. Be that as it may, there is a huge unmet need for techniques to reduce the risk of LVOT obstruction with TMVR. And one of the strategies is preemptive alcohol septal ablation, and sites have started doing this. Here's a quick example. You can see the patient with a small neo-LVOT. This is a virtual valve, and based on the CT, they had a small neo-LVOT, and they were prohibitive risk for TMVR. After alcohol septal ablation, you can clearly see that the neo-LVOT has increased in size, and so we are learning more as we go along. Of course, there are challenges in terms of selecting the appropriate perforator. Septal thickness, this is not a HOCM population. Not all of them have very thick septum. So this is something that is challenging. And of course, there is a wait time to let the septum shrink and the neo-LVOT enlarge. The other technique that is emerging is something called lampoon, which is intentional laceration of the anterior leaflet. This is an electrosurgical technique with the help of guide catheters. that are sort of married, and a wire is exteriorized from the vein out to the artery on the other side, and electrosurgical techniques are used to cut the anterior leaflet and thereby allowing flow through a sapien valve. You can see the open cell here, reducing the risk of alveolar obstruction. There are challenges with this as well. This is technically challenging. It may not be feasible if the leaflet is very calcified. May not work in TMVR without an open cell design like the sapien valve. It may not resolve alveolar obstruction. So these are things that are evolving, and we are learning more and more. Just one slide on the spectrum of other interventions. So sapien valves in valve for a degenerated prosthetic mitral valve, and degenerated or recurrent MR after a prosthetic ring. These are both FDA approved. Valve in MAC, this is a off-label use of the sapien valve. This is a high-risk patient population with high 30-day and 1-year mortality, but there are emerging data, and we are learning more about this patient population. Just a quick slide on pipeline device. This is a Gore device. This may allow us to put neocords through degenerative mitral leaflets via transfemoral transseptal route. So this is something that is evolving. In the last few minutes, I'd like to talk a little bit about the forgotten valve. Hopefully, it's not forgotten anymore. We've all seen these patients with marked JVD, ascites, lower extremity edema, right heart failure. They're miserable. And I don't need to tell you the anatomy. As tricuspid annulus enlarges, the patients develop worsening TR. There's a huge unmet need. There's a very small proportion of patients with TR that are actually treated, in contrast to aortic and mitral valve disease. Most of the TR is functional, seconded to left-sided abnormalities or pulmonary hypertension. And important things we are learning about TR as we are in the transcatheter tricuspid space is that the TR is no longer mild, moderate, or severe. We have identified also massive and torrential tricuspid regurgitation, and here are the echo criteria by Becky Hahn and Dr. Zogby. This is important because there is patients with massive and torrential actually do worse in terms of clinical outcomes than moderate or severe MR. The other thing that we've learned in the last couple of years is the nomenclature. We used to think of tricuspid valve as 3 cusps. Well, that only happens in 54% patients. This is from Becky Hahn, published in JACC Imaging. So there are now 5 different categories of or nomenclature for tricuspid valve. So the traditional 3 leaflet is found only in about half the patients. In a substantial number of patients, there are actually 4 cusps or 4 leaflets, as you can see in the middle panel, and then in a small group of patients, there are actually 5 cusps. This becomes important, especially when we're talking about edge-to-edge repair, in terms of clipping or grasping which leaflets we are going to grasp. We'll skip through this. So what are the options for tricuspid transcatheter interventions? Well, there are annular techniques, there is leaflet apposition techniques, and there is transcatheter valve replacement. So the TriLuminate feasibility study was the initial study looking at about 85 patients who underwent TriClip. About 70% of the times they had the anterior and septal leaflet clipping. And the TR reduction was modest, but still better than medical therapy alone. TR reduced to moderate or less in 70% of patients compared to 8% at baseline. And NYHA functional class improved out to 1 year. In the interest of time, we'll skip through the case. The TriLuminate pivotal trial is the key trial that we are all awaiting, looking at. This is a randomized trial, randomizing patients with severe TR to tricuspid clip versus medical therapy alone, 450 patients. And this trial has been completed and is going to be presented at ACC next month. So results are eagerly awaited. This is a study from Europe, from the TriValve registry. They looked at 400 patients undergoing tricuspid intervention and propensity matched them with medical therapy. And again, survival and freedom from heart failure was higher in patients undergoing intervention. So there are signals from retrospective studies that intervention may be better than medical therapy alone. Lastly, the TTVR landscape, which is tricuspid valve replacement, is also rapidly expanding, just like the mitral valve replacement. EVOQUE is the Edwards transcatheter valve. A lot has been written about this, and this is a small early feasibility study looking at 25 patients, 0% mortality at 30 days, TR2 plus or less in 96% patients. So just like TMVR, TTVR appears to be very good at eliminating regurgitation. Of course, we need to study the appropriate patients and safety of these devices. And lastly, the trick valve. This is an interesting bicaval valve, which essentially leaves the native tricuspid valve alone. And this is currently being studied in a compassionate use fashion, but they have plans to enroll this in an early feasibility trial. And just like mitral, what we need to learn as we go along is which patients may be suitable for edge-to-edge repair and which patients perhaps will do better with a transcatheter valve replacement. There's a lot that we don't know right now. So just to summarize, what have we learned and where we're going? So I think from mitral standpoint, what we've learned is that TEER is safe and effective treatment of DMR when surgical risk is high and anatomy is appropriate. Advancement in TEER technology and experience is improving outcomes. TEER versus surgery RCT is ongoing for DMR in intermediate surgical risk. TEER is a good option on top of GDMT in FMR patients. We need better anatomic criteria or characterization for suboptimal candidates because these are patients that will be suitable for TMVR. Of course, TMVR is very good at eliminating MR. Right now, anatomical exclusion rate is high due to annulus size and LVOT risk. And we are going to see randomized trials of TEER with TMVR in the near future. How about tricuspid? So most data currently exists with TEER. We are eagerly awaiting the results of the TriLuminate pivotal study, which is going to be presented at ACC next month. The optimal timing and strategy, repair versus replacement, remains to be seen. Patient selection. And then, of course, we need more data on leads, RV function, and impact of pH in this patient population. With this, I would like to end, and I'll be happy to answer any questions. Thank you.
Well, wow. Sachin, thank you very much for doing that. That was an astounding presentation, completely data-rich. For those of us who've been involved, it's still incredibly enlightening. So, and the other thing I'd like to point out is I'm amazed that with that huge amount of data, you were able to finish not even on time, but early. So, round of applause, please. And let's get some questions. Boss.
Sachin, that was wonderful. Very comprehensive, and I think it also points to the amazing speed that we're getting more and more information regarding catheter-based interventions, particularly for the mitral valve. The question to you and Neil maybe is, it looks like unless we have another randomized trial for similar to COAPT, that everything you point out to should be a class 1 indication in the high-risk patient. And we're still at 2A at this stage of the game. But I think practically, it's almost like a class 1 indication. And the question is there on the horizon another randomized trial with similar, COAPT criteria? It could be for another TEER procedure to push it to a class 1 indication.
Yeah, that's a great question, Dr. Zaghi. So there actually is, not with the Mitra clip itself, but there's an ongoing randomized trial, the CLASP 2F, but that is randomizing the Pascal device to the Mitra clip. So it's not randomized to medical therapy. So there are other TEER devices that are being studied, but you're absolutely right that, in our minds, these patients, we treat them like a class 1 indication, but as you know, for a class 1 indication, we need to have multiple randomized trials, which, I think are unlikely to happen. So the technology, I think, is evolving, and you will see more devices compared against the existing devices, number one. Number two, we'll see newer versions or newer iterations of the existing technology, as we are seeing with the Expand and Expand G4, which is showing improving outcomes. But I think to conduct a study like COAPT, which is randomized, functional MR to GDMT, I think that is unlikely to happen anytime soon.
One quick one before, in comparing, you shared with us the challenges of a TMVR, which is LVOT obstruction. What are the challenges on the right side for a total tricuspid valve replacement?
Great question. So the challenges, I think, on the right side, first of all, is with current devices is the sizing. A lot of the times, these patients that we are seeing with TR, they are already far advanced, and their annuli are too big. So one of the main reasons patients get excluded for TTVR is annular sizing. Annulus is too big. So that's number one. Number two, the risk of pacemaker. Even with the current data, the risk of pacemaker is about 8 to 10%. And number three, the challenge with the tricuspid also is the angle or the anatomy between the tricuspid and the IVC. So these are some of the main challenges with TTVR. In addition, of course, patient selection.
Great talk, Sachin. So my question is, I've taken care of many patients that did not get the benefit of MitraClip. I mean, from a heart failure standpoint, they progressed to VADs and transplants. So, that's where we struggle, right? I mean, who will benefit, who will not benefit? I think the concept of proportionate, disproportionate helps, but I think we need tools beyond, echo or hemodynamics. So my question is, do we have any data regarding viability testing to decide candidacy for MitraClip, number one? Number two, to also help in response for MitraClip?
Good question. So I think the first part, the viability part, I don't think that has been looked at for MitraClip. I mean, I think from the coronary, literature, we've seen that data is irrelevant. So I mean, I don't think the viability part is going to be, an important one for MR. The way I like to think of it, and most of us like to think of VAD versus MitraClip is, VAD is a very big endeavor. The MitraClip is extremely safe. I think as long as patients are meeting the COAPT criteria, they should be referred for MitraClip. As Dr. Zogby pointed out, it's a class 2A, but in my mind, it is a class 1 indication if you've already optimized them and there's nothing else to offer other than an LVAD. These patients should be referred for MitraClip. By doing a MitraClip, you don't burn any bridges. You still have the option of LVAD and advanced options down the line. But as we saw from some of the literature, some of these patients actually clinically improve and they don't need a VAD or a transplant. So in my mind, MitraClip first and VAD later.
Sachin, that was a great talk. Thank you for all that. I'll have to go to our YouTube channel and watch it a few times just to digest all the data that you provided, so that's great. A couple of things. First of all, I think MitraClip has been a great thing for functional mitral regurgitation patients, no question, and I agree with Bill about the fact that it probably should be used more, than it is. And as you well know, the surgical outcomes in these very high-risk patients with FMR are not great. Just as an aside, the CTSNet trial that was published in 2016, funded by the NIH, looked at 2-year outcomes for patients with severe FMR at mitral repair versus mitral replacement, and replacement had fewer heart failure, and it was basically more effective. But the caveat is the mortality and the morbidity in that patient population when you operate on them is high. I would caution you, though, about being too aggressive about using it in the DMR, degenerative mitral regurgitation population, as you get down into the intermediate, because surgical outcomes are very good for patients with degenerative mitral regurgitation. Repair rates at institutions like this exceed 97, 98%. And if you get a suboptimal outcome with a clip in those patients such that you determine that at some point they need a surgical intervention, it may be 2 years, 3 years down the line, they're basically going to need to have a mitral valve replacement. So I think that should factor into one's decision-making. But great talk. Thank you.
Absolutely. That's a great point, Mahesh. Thank you.
So, Sachin, let me come back to Dr. Zogby's original question. The future of TEER versus GDMT alone trials. When we did COAPT and we screened patients, one of the requirements, which was really painful to us, but very wise, I think, was that patients be titrated very meticulously to what was at the time GDMT, and stable on that for a prolonged period of time before being reevaluated for the presence of secondary MR. And what we saw was, and this is not talked about a lot, but about half of those patients had MR that got a lot better. What we don't know is how long they stay better and whether proceeding with TEER anyway would have been beneficial. Were we seeing a snapshot of a roller coaster temporal course, or were we seeing a relatively permanent improvement? So do you think that is a population that we ought to be looking at? That is, patients who aren't yet on full GDM, or who aren't yet stable on full GDMT?
That's a great question, Dr. Kleiman. And I think one of the slides I did not show here, what we learned from COAPT is when we look at the left ventricular size, the left ventricular end diastolic and end systolic volumes, in the medical therapy, in the GDMT alone group, the LV continues to dilate. So over time, the ventricular size enlarges, whereas in the MitraClip arm, the LV enlargement slows down. So
these are patients who got through screening.
right.
Still had
Right, right. So the point I'm trying to make is, even with GDMT, as you said, the MR improves, but the results are not durable because they continue to have LV enlargement, and they have more MR. And so the MR reduction was more durable with CLIP compared to GDMT. So I think that is a very important point. I think we don't have a whole lot of data on these kinds of patients. And the other thing that I always wonder is, sometimes, we are not able to push the GDMT. We can't get these patients on high doses or COAPT-like doses because they are limited by, side effects or low blood pressure. So one of the other things that I always wonder is, whether doing a MitraClip will allow us to, to institute more GDMT for their underlying cardiomyopathy. So these are all good questions that I don't think we have a whole lot of data yet.
Oh, thank you, Sergeant. Excellent talk. Just to emphasize and support a couple of your comments, the referral of these patients is critically important, quite a bit different. Primary MR medical therapy has no effect whatsoever on the course of the illness. It only delays and covers up progressive deterioration of the LV. And the Mayo Clinic also published a paper sometime earlier on their Olmsted County people they'd seen and done an echo, and it was a catastrophe. These people were all showing up in heart failure 5 to 7 years later. So early referral is critical, and temporizing with medical therapy in primary MR is actually contraindicated. As far as surgery is concerned, we have progressed a lot since the earlier randomized study, and we published a series of 1,000 patients. My own experience here with Dr. Zogby and Dr. Little, and we had 100% repairability, 0.5% mortality, 2 millimeter perioperative mitral gradient, and 0 MR leaving the OR. And at 10 to 15 years follow-up, the need for reintervention is 5%. So, but 90% of our patients had been referred late. They were either in AFib or had some deterioration of LV function, more than class 2 symptoms, actual congestive heart failure. So referral, and that did affect the long-term survival. As far as mitral stenosis is concerned, there have been a number of studies in the CLIP literature, as you know, that have shown somewhere around that 4 to 5 millimeter mark is adverse. There was a very good surgical study from Canada from a multi-center randomized trial of actual resection versus replacement, but they had a subgroup they analyzed with mitral stenosis, and they found a cutoff of 5 millimeters, which translates to about an 18 millimeter gradient on exercise, was a point at which people started getting pulmonary hypertension late after surgery. And then just on the subject of atriogenic mitral regurgitation, this is a real entity. The posterior mitral annulus is not a very strong structure. It is not a fibrous ring. It is often an interrupted series of gaps filled with fibrofatty tissue that allow the posterior annulus to be mobile. The lower part of the left atrium has a circumferential sphincter in its posterior portion, and we know that left atrial contraction is essential for the rapid late filling of the ventricle, which leads to apposition of the mitral leaflet. So loss of sinus rhythm, you lose the sphincter, atrial sphincter, and you lose the late filling. So this condition is very amenable to just simple ring annuloplasty, which we currently do surgically with very good results. Obviously, the future is with catheter-based therapy, but I think for the present, I think Mahesh's point is very important. We have several large definitive studies showing that almost no people can be repaired after a MitraClip more than a few weeks after the surgery. And if we have a young patient and they need a replacement, they're going to need a mechanical prosthesis. I think for the moment we need to just ponder before we start instituting MitraClips in the younger population with degenerative disease. But excellent talk, thank you.
Thank you very much for your comments.
I wanted to share with you maybe 2 areas of research that we have to concentrate on. It is not black and white, the difference between MITRA-FR and coapt. And I'll tell you, the concept of disproportionate MR is important, but there are a lot of suppositions as to what the entity is. But if you think about size of the ventricle and severity of the regurgitation, these 2 variables were different between the 2 trials. So the ventricle was larger and the severity was less.
Yep.
So the big question to us is, maybe if the ventricle is too large, it's not going to affect prognosis. Some of this, particularly if the MR is milder. So the question is, if we intervene on patients with an effective regurgitant orifice area greater than 0.2, as opposed to 0.3, yet the ventricle is not too bad, maybe the outcome would be good. So these are the 2 variables that were different, and I cannot tell you whether we know if they're both of them different, the outcome appears to be different. But if one of them is, and the reason I'm raising this is in the echo lab, and many of these criteria are because of echo criteria of effective regurgitant orifice area, is that you rarely see in functional mitral regurgitation greater than 0.4 or 0.3. So the vast majority of functional regurgitation are lying between 0.2 and 0.3, and that's part of the large exclusion criteria that you have. So this is an important one for us to really go after.
Great point. Thank you. Thank you very much.